welcome everyone. It's good to see so many of you turn up to this session, which is really relevant. So I'm Archie. I'm one of the junior doctors at St Vincent's Hospital in Melbourne. We've got a great topic of antiemetics today, which is so relevant, not only for crit care rotations, but sort of any rotation that you do, whether that be in your med school or whether that be as a junior doctor. So I just want to introduce our fantastic facilitator and speaker today, Dr. Nik, a critical care resident who can take us through the topic. So if you could, we'd absolutely sort of love it if you could turn on your cameras and help Nik. We don't mind where you are. You can be in bed, whatever. We don't really care as long as you engage a little bit. I'll be monitoring the chat for any questions, so and I can pass them on to Nik as well. But if you do want to speak up, it's more than encouraged to be for you guys to sort of speak up and ask a question. So please do so. The lecture is also going to be recorded online, and then we can pop it up on YouTube in a few weeks' time. So that'll be good. And then at the end, Nik will show you a QR code at the end of the lecture. It'll take 30 seconds max. So please take time to get this feedback on. It'll really help us sort of shape how we run our next future sessions. So without further delay, I'd like to introduce Dr. Nik. Nik, take it away.
Hi guys, as Archie's already introduced, I'm Nik, and today we're going to be talking about postoperative nausea and vomiting, as well as the antiemetics you'll be using on the wards. I think this one's a really relevant topic. We're going to talk about a whole number of different things, and just to introduce myself at the start, for those of you that don't know me, my name's Nik. I'm a critical care resident at Western Health. I'm currently PGY 4. I'll be starting anaesthetics training next year, and I enjoy teaching and learning, which is why I'm here today. So here are some links to the ABCs of Anesthesia resources. You can catch the ABCs on Twitter, Instagram, or Facebook page and group. Now, some basic rules and assumptions for everyone. Want lots of questions, lots of writing, speaking, and having a go. Want you to know you're all capable and intelligent, have done your best to be the best by turning up today. So it doesn't matter if you get something right or wrong. I want to use this as a learning opportunity so that we can all grow and develop from this. Now, in terms of the learning objectives that I want to cover today, I want us to be able to define nausea, vomiting, and regurgitation so that we can differentiate between them and address them appropriately. I want us to be able to understand the implications of postoperative nausea and vomiting, so why we care about it. And then understand the pharmacology of various antiemetics so that you know which one to give at which time. And then also know how to treat postoperative nausea and vomiting, as well as nausea and vomiting throughout the ward. So I'm going to start off with some definitions. Nathan, you're first up. Would you be able to give me a definition for nausea?
I guess it's a symptom, and I guess it's a feeling of unpleasantness, or I don't really have a good one.
No, you've actually hit the nail on the head with that. That's exactly right. It's an unpleasant sensation that you might feel. It's associated with the urge to vomit, right? You might feel it in the stomach, you might feel it in the throat. And then going on from there, then we've got vomiting. And that's the active expulsion of stomach contents through the mouth, okay? And that's different to, say, something like regurgitation, which is a passive movement, right? So you have the passive movement of stomach contents through the esophagus and into the mouth. And that's associated with an unconscious patient, potentially a patient with reduced GCS, someone who might be sleeping, where the esophageal sphincters are quite incompetent and the patient's lost a lot of their airway reflexes. So that's the difference. Vomiting is active, regurgitation is passive, and nausea is that unpleasant sensation that is associated with vomiting. Now, why do we care about postoperative nausea and vomiting in general? Aidan Uwe, I might ask you this one. We'll just brainstorm a couple of things, and then we'll talk about some important reasons as to why we address this.
Sure. I mean, firstly, risk of aspiration. So, which, it could lead to aspiration pneumonia and more serious complications. And I guess other things, obviously, it's just unpleasant for the patient. And that, and also, I guess, other consequences of vomiting may be like loss of fluid, electrolyte imbalance, leading to potential other complications down the track.
Those are actually extremely relevant points. I like it. And you spoke about a few of the things that I've got on this slide as well. Can you think of anything else in terms of hospital flow and what it might mean for a patient?
Well, delayed discharges. If
That's it.
Yeah.
Brilliant. Aidan, you covered all of them. So it's unpleasant for the patient. It delays discharge. So if they've got postoperative nausea and vomiting, they're reliant on IV fluids. They can't take anything in orally. And as a result of that, they're going to need to stay in hospital for an extra night for that to be addressed. And in addition to this, if a patient's feeling unwell and they're constantly vomiting, they're unlikely to get up and mobilize. And likewise, they're unable to take their oral analgesia. And as a result of this, that will also delay healing and recovery, as again, they won't be able to mobilize as a result of that. And one other thing that's actually not mentioned on this slide that I wanted to highlight is the fact that if a patient's had like intra-abdominal surgery or surgery in a very sensitive area, the actual act of vomiting and that Valsalva maneuver may actually compromise the surgical wound site as well. So that's something to keep in mind. Now, as far as postoperative risk factors go, I'm going to ask Kate, do you know some of the postoperative nausea and vomiting risk factors?
I guess the type of surgery would probably impact the likelihood of nausea and vomiting. So maybe abdominal surgeries and things like that.
Brilliant. So you're about to say a few things. Do you have a way of categorizing these risks?
Probably, I guess there's like patient factors, and then surgical factors. I'm not sure what else.
Anesthetic factors. So we'll go over it. Some patient factors that might influence postoperative nausea and vomiting risk. You know what they might be?
Someone said young female in the chat.
Yep, that is actually. So those are some of the risk factors. So patient factors, surgical factors, and anesthetic factors. From a patient perspective, younger adults are more likely than older adults because they're more sensitive to the things that cause nausea. Females are more sensitive than males. If you've had a previous history of postoperative nausea and vomiting or previous motion sickness, that's a really good predictor of things experiencing that in the future, as well as if you're a non-smoker. And that's because you're more sensitive to some of those stimuli that cause nausea. And then lastly, if you've got a full stomach or gastroparesis, whether it's as a result of type 2 diabetes or excessive opioid use, that can also precipitate this issue. Now, Kate, you were talking about surgical factors and you highlighted a really good one, which was intra-abdominal surgery. Do you know any other surgical factors?
I would think a longer surgery, probably.
Brilliant. So prolonged surgery and laparotomy or laparoscopic surgery. And then the other ones that aren't so straightforward is middle ear and ENT surgery. And that's because you're messing with the vestibular system, which pretty much coordinates eye movement with movement in space. And that can lead to dizziness and the sensation of nausea as well. Now, in terms of anesthetic factors, using general anesthesia as opposed to regional anesthesia has a higher risk for obvious reasons. You're giving a lot of medications that can precipitate it. Giving volatile or nitrous oxide can precipitate nausea and vomiting as well. So there's a preference for TIVA in patients who are high risk. So that's the administration of just propofol rather than volatile. And then opioid use. Essentially, giving extensive opioid use can also lead to postoperative nausea and vomiting. Good work, Kate. Now, we're going to go with Stevie. Stevie, do you know anything about the APFL score or how we stratify risk factors in PONV?
I've never heard of the APFL score.
Okay.
But I assume that some factors have more weight than others.
That's exactly right. So it relies very much mostly on patient factors. So can you think about some of the patient factors you might relate to?
I feel as though past history would be a big one.
That is one of the factors. So there's only 4 factors for this. Past history of PONV or having motion sickness is actually one of the risk factors for this. Can you think of any other ones? Just guess it. It's actually, we'll brainstorm together and I'm sure we'll get them.
Okay. Because I feel like there's a clear physiological cause there.
What was that one you said, Stevie?
Non-smoker.
That's actually one of the other ones. So you've got 2 out of 4 so far.
Young and female?
So female is one. Young is one on the recent guidelines, not so much on the APFL score. So we'll go over it. So being a female, being a non-smoker, having a history of previous PONV or motion sickness, and then post-operative opioid use will give you a point for each of these. And it's important to take a photo of this at the end for your anesthetic rotations as well, as you'll probably impress your bosses knowing this in advance. And then you tally up the scores, and that'll tell you what someone's risk is of getting PONV in the next 24 hours. So you can see if you've got 4 risk factors, your risk is 79%. And we use this calculation to determine how many antiemetics we're going to give over that as preventatives as part of our anesthetic plan. So based off this score, if you've got 0 to 1 risk factors, you're going to get nothing. If you've got 2, you're going to get 1 or 2. And then you've got 3 or 4, you're going to get 3 or more. Now, this is a little bit different to our more recent guidelines that were developed in 2020, although a lot of people still refer to the APFL score, where you've got your risk factors. There's a few other risk factors. So as you mentioned, Stevie, younger age is on there as well as the surgical type. And then you think about your risk mitigation strategies. So what you're going to do to prevent it from occurring. So reducing the use of opioids, utilizing a regional approach rather than a volatile approach. And then again, reducing the amount of volatiles you're going to use. Then you go into risk stratification, where you think about how many risk factors they have and how many interventions you'll give. And you think about prophylaxis, the stuff you're definitely going to give, and then rescue therapy, the stuff you're going to give if that's not enough. Now, this is different to the previous APFL score in that if you've got 1 risk factor, you still get 2 agents. So that's worth noting. Pretty much everyone in anesthesia, if they're going to get a GA, they're more than likely going to get at least 1 or 2 antiemetics. So just keep that in mind for your rotations. Good work, Stevie.
Nick, we just had a question in the chat whether brain surgery or intracranial surgery would increase PONV risk.
So I can see young female for sure, yep. And then would brain surgery increase PONV risk? So brain surgery, from my understanding, by increasing intracranial pressure as a result of the inflammation and everything that could happen afterwards. I don't know the specifics in terms of the research surrounding it, but I would suspect it would have an increased risk. But that's just based off my, I guess, anecdotal experience. So we'll go over some of the pathophysiology now. And I'm sure you guys have probably already gone over this in medical school, but it's good to revisit these things. Jane Chook, I might ask you some questions about the pathophys. Do you understand anything about the vomiting centers and the pathophysiology of nausea? Jane Chook? No, they're not there. That's all right. We'll go with Caitlin McRitchie.
I would guess like the chemoreceptor sort of trigger zone, like a vestibular apparatus, maybe a bit of like cerebral cortex and from the gut itself as well.
You answered all of it. So we'll start off with the chemoreceptor trigger zone. Do you know what's important or specific about this zone and why it's so significant in nausea and vomiting? There's one particular differentiating feature compared to the others.
I'm not sure, actually.
So the vomiting center is in the medulla oblongata, and the chemoreceptor trigger zones are also in the medulla oblongata. But the difference with the chemoreceptor trigger zone, it's actually separate to the blood-brain barrier. So a lot of the blood-borne emetogenic agents are able to directly interact with this zone through these receptors, and then that's sent to the vomiting center that can provoke nausea and vomiting. So that's actually the differentiating feature on why this center is so important, is because it can actually sense stimuli in the peripheral blood, in your systemic circulation, as opposed to some of the other areas like the nucleus tractus solitarius, which, like you mentioned, gets input from the gastrointestinal tract. Also, the pharynx has the same receptor sites as the chemoreceptor trigger zone. And then we've got the vestibular system that relies mostly on histaminergic and muscarinic receptors. And like you said, the cerebral cortex, the higher brain centers. So you can probably think back to a time when you remember an experience where you may have smelt something, seen something, or felt something that sort of made you feel a bit nauseous. And then reliving that can also reproduce those symptoms of nausea and vomiting as well. So multiple different inputs. What's important to acknowledge is the different receptor types in each of these systems, because depending on what's causing the nausea and vomiting will determine which drug you're going to give. Good work there, Caitlin. So we're going to go on to the most commonly used antiemetic agent at the moment. Does anyone want to volunteer and tell me what it is?
Ondansetron.
Beautiful. And how does ondansetron work?
It's a 5-HT3 antagonist.
Beautiful. And what's that? What neurotransmitter does that work on?
Serotonin.
Beautiful. Do you know what the dose of ondansetron is?
It can vary, but roughly 4 milligrams, depending on what you're doing, sublingual or IV.
Yeah, exactly. So you can give it IV, sublingual, 4 to 8 milligrams, TDS. Brilliant. It's an amazing drug because it's really sensitive, right? It's really sensitive for those serotonin receptors. So it'll work at the chemoreceptor trigger zone, the gastrointestinal tract, as well as the nucleus tractus solitarius, but it won't work anywhere else very much. And as a result of that, you don't get much side effects. The one to be aware of, though, is constipation. If you've done a palliative care rotation, I think they try to opt away from this because there's a lot of patients there that might have like a bowel obstruction and they're trying to, or they might be already constipated and they don't want to make that any worse. So that's something to keep in mind. And then I guess the prolonged QT syndrome is quite rare, but otherwise it's a brilliant drug. And this is the drug you're often going to see given within anesthetics and as well as on the ward. Now we've got I want to talk about the dopamine antagonists. There's quite a number of these. We'll talk about the common ones and then some of the other ones. I'll go with Justin Lim. Are you there, Justin?
Yep.
Beautiful. Do you know of any dopaminergic antiemetics?
Metoclopramide.
Beautiful. And that's the one we're going to talk about. So metoclopramide, do you know the dose of metoclopramide?
No, I don't know the dose.
That's okay. So it's 10 milligrams TDS typically. You can give it PO or IV. It's referred to as a relatively dirty drug because it does work on your D2 receptors and it antagonizes them centrally. And it also works peripherally to increase gastric motility. But it also works on your serotonin receptors and your histaminergic receptors. And I believe based on some of the research, it has a very high number needed to treat to actually work. So it's not the greatest antiemetic, but it's something that's been around for quite some time, so we all know about it. Does anyone know where you might want to actually, Justin, do you know in what circumstances we might want to avoid metoclopramide?
For patients with like Parkinson's disease, where you don't want to block their dopamine centrally.
Exactly. So they're lacking dopamine, and if you block it centrally, you're going to get worsening of the extrapyramidal symptoms. There's another sort of red flag thing that you don't want to give metoclopramide with, and it's got to do with the fact that it's a proclinic agent.
If there's any, I was going to say bowel obstruction.
Exactly. So with bowel obstruction, you don't want to be pushing. You've got an obstruction. You do not want to be pushing against that obstruction and increasing intraluminal pressures because that could lead to a perforation. I think it's still relatively rare, but it's not a risk you want to take. So you'd keep with ondansetron in those circumstances. So I've already gone over the side effects. You guys are all over it. Now, I've got a couple of other drugs. And it's okay if you guys don't know them. We'll go through them together. I think the next person I'll go with is Conrad. Can you tell me some other dopaminergic or dopamine antagonists that you know of that we use as antiemetics?
I'm actually not sure if I know any more, to be honest.
That's okay. So the other ones that we'll talk about is prochlorperazine. Have you guys ever heard of Stemetil being used on the ward? Probably used mainly for patients that are dizzy for benign causes. And that's a D2 antagonist, but it's also got some histaminergic and muscarinic receptor antagonism as well. And that's particularly useful for patients who have vestibular causes of their nausea and vomiting. And that's that patient that's dizzy from a benign cause, like benign paroxysmal positional vertigo. Side effects are essentially very similar to the side effects you experience with metoclopramide. So just be wary of that. And then you've got droperidol. Mainly, we use it as an antiemetic within anesthesia. Again, D2 antagonist, and has a very similar side effect profile to metoclopramide. And we give it at the end of our anesthetic course, just as a subsequent prophylactic drug that we can use. Typical dose of this is 0.625 milligrams IV. And then domperidone's an interesting one. That's also a dopamine antagonist, but the reason why this one's different to all the other ones is that it doesn't actually cross the blood-brain barrier. So prochlorperazine and droperidol you would want to avoid in Parkinsonism. Same thing with metoclopramide, but domperidone might be okay. I never use it personally. I try to avoid them altogether, but because it doesn't cross the blood-brain barrier, that risk of exacerbating Parkinson's-like syndromes is reduced. So that's something just to keep in mind. Now I've got our antihistamines. Does anyone know of any antihistamines that we use as antiemetics?
So you've got like promethazine.
Yep.
Cyclazine, someone's put in the chat.
Cyclazine. So cyclazine's the one I was going to talk about because that's one of the more common ones you use in anesthetics. Typically, you give 50 megs TDS, works at the histaminergic receptors and the chemoreceptor trigger zone, the nucleus tractus solitarius, and also the vestibular system. Now, the side effects of antihistamines, they typically make you tired and sort of a bit sedated. So it's something you want to be very cautious of, particularly after an anesthetic when you've got someone who's already quite out of it, a bit vasoplegic, can worsen that. So you want to make sure they're pretty well when you're giving it. It also has those anticholinergic effects to be aware of as well. Now, corticosteroids are the other one to talk about. Now, let me just check we've got some things in the chat. Lovely. Now, Lom, are you there, Lom?
Yep.
Beautiful.
Here.
Now, you mentioned something about brain surgery increasing PONV risk.
Yep.
Sort of an kind of related question. Do you know what sort of an antiemetic you'd use in a patient who might have like a brain tumor? So a lot of inflammation.
Is it dexamethasone?
Yeah, that's right. And do you know where else we use it as well?
Is it in cancer? Like chemotherapy? Is that?
Chemotherapy, brilliant. And there's one more.
I'm not sure.
That's okay.
That's all I know.
We actually use it as the starting antiemetic in anesthetics, which a lot of people don't know about. So the reason why corticosteroids work, we're not entirely sure. Reduces prostaglandin synthesis. And we know that they take some time to work because they have to act on the nuclear receptors to influence gene transcription and protein synthesis. So typically give them at induction to give them time to work by the time the case is over. Same thing with chemotherapy. You give it before chemotherapy so that by the time that's commenced, that it's done, the patient has some antiemetic effects. Now, side effects wise, the same stuff you'd get with any sort of steroid that you're going to give a patient, like corticosteroids, like hypoglycemia, perineal pain's a problem if you administer the medication too quickly. And under anesthesia, you see this as an elevated heart rate and an elevated blood pressure. Immunosuppression has typically been something that's been talked about within anesthetics as well. Now, if you look at some of the recent studies, it suggests that the immunosuppression isn't relevant when you use it as antiemetic doses. Now I've got propofol, and this one I'll just go through briefly because it's pretty straightforward. It's one that we don't know a whole heap about. Works on the GABAergic system. And the reason why propofol is great is, on one hand, it actually reduces the need of using volatile agents, which can provoke nausea and vomiting. But on the other hand, it actually has antiemetic properties itself. So if you've got a high-risk patient with 3 or 4 risk factors, you might opt to give them Tiva as a result, as an addition. You'd opt to give them Tiva instead of giving them like a volatile anesthetic, like sevoflurane, for instance. And that'll help mitigate the risk. Now, the drug dosages, they're not super important at your stage. It's typically 1 to 2 milligrams for induction to get the patient asleep. And then maintenance dose is typically determined by your TCI pump. And of course, the side effects it has is largely the reasons why we have anaesthetists providing it. Causes respiratory depression, so you need airway skills. It causes hemodynamic stability that can give rise to cardiovascular issues. So you need someone who can optimize those hemodynamics when it's administered. But otherwise, a great drug to be using as part of your anesthetic plan. All right, so that's actually all the drugs. We can go back on them all. Any questions at this point? Oh, I've got one in the chat. Let's have a look. So non-smokers are typically at higher risk because I guess the act of smoking is something that can provoke nausea. And when they've been doing it for so long, I mean, this is my simple explanation of it, they're desensitized to the effects and the sensation of nausea. And that's the reason. Does that answer your question, Long?
Yeah, that makes sense.
Yeah, exactly. All right, now onto some cases. Now, do we have a volunteer for the first case? And again, these cases may seem complex. We'll go through them step by step and just talk about what we'll do. All right, comrade, let's go through it. So you got a 25-year-old female having a GA for an elective laparoscopic cholecystectomy. They don't smoke and they have no prior history of motion sickness. And she's otherwise well with no past medical history. If you were the anesthetics HMO, what will you plan to give her from an antiemetic perspective? I just want to start. What's your level, Conrad?
I'm a final year med student.
Awesome. Okay. What would be your plan in this instance?
So she's clearly high risk for postoperative nausea and vomiting.
Yep.
So I'd give
What
3
makes you?
antibiotics.
I just want to go on to that. What makes you say she's high risk? What factors?
Yeah, so patient factors, it's a young female, non-smoker. And then I guess in terms of surgical factors, it's a laparoscopic abdominal surgery.
Yep. Brilliant. The other thing to keep in mind is this is a surgery that require postoperative opioids.
Mhm.
So depending on whether you use the APFL score or the new guidelines, typically you're going to need about 3 or 4 agents. What sort of agents do you think you'd use in this instance?
So I guess you would do dexamethasone.
Brilliant.
At
Dexamethasone
induction.
at the start. That's exactly what you do. Yep.
And then maybe ondansetron at the end of the surgery, and like droperidol or metoclopramide as well.
Brilliant. That's exactly what I would do. Is there anything else you'd do in addition to that? Because this patient's high risk.
Yeah, you could consider using Tiva.
That's it, mate. You got it all. Smashed it. That's exactly what I would be doing in this instance. So I'd be opting for Tiva as maintenance because this patient's high risk. I'm going to give him dexamethasone at the start of the procedure, some ondansetron at the end, as well as some droperidol at the end. And then, you may consider some rescue therapy, you can consider adding in some cyclizine or something like that. But I think this would be sufficient to address this patient's risks. And it'd be pretty much the same protocol, whether you look at the APFL score or whether you look at the new guidelines. It'd be very similar. Good work. All right, now we're going to go on to the second case. Do we have any volunteers for this one?
Yeah, I can do this case.
All right, brilliant. Let's go through it. Okay, so you're an intern on the ward and you've been asked to chart an antiemetic for a 67-year-old woman who's been admitted with a large bowel obstruction. What antiemetic are you going to use and why?
So I guess looking at this stem, she's got a bowel obstruction. We want to avoid anything with a prokinetic effect, such as metoclopramide.
Brilliant.
You would want to assess her other medical conditions and any contraindications to other antiemetics. But I think for this, you could be looking at a ondansetron or potentially something with a dopaminergic or histaminergic. But yeah, like I said, avoiding any prokinetic drugs.
Brilliant. Yeah. So cyclizine's the other one that isn't really a prokinetic agent from my experience. And I think it's one that I've opted for in the past when I've been in ED and someone's got a bowel obstruction or ondansetron isn't cutting it. In terms of, yeah, that's it. That's essentially it. It's a selective drug. You don't want to give any D2 antagonists because you don't have those prokinetic effects. That's exactly the right answer. That's what I'd be doing in this instance. And then you'd also think about decompression, getting an NG tube in, making sure that you can, reduce those contents in there, and that'll help resolve some of the symptoms. So you're sort of non-pharmacological as well as pharmacological interventions. Great work, Nathan. All right, next case. Who's happy to volunteer for this one? Otherwise, we'll choose a volunteer. Lewis Sigan, beloved.
Yep.
Brilliant. What's your level?
I'm a third year.
All right, brilliant. So that's completely okay. We're going to go through this one together. So you're covering the palliative care ward as a resident. You've been asked to admit a 75-year-old man with a glioblastoma multiforme for comfort care. So that's just a very aggressive brain tumor. They've got a headache and they've been unable to eat or drink due to nausea. Which antiemetic are you going to use, or which one are you going to consider charting in this instance?
Because they have a headache, I feel like you avoid on ondansetron in this case.
So
Yeah.
the headache wouldn't necessarily be a contraindication to ondans, I guess. I mean, it's a risk factor, but it's never stopped me from giving it. Now, think about the pathology this patient has. They've got a GBM, right? That's going to cause a lot of inflammation in the brain. That's probably one of the reasons why they've got this headache.
So would you use dexamethasone then?
That's right. You'd use dexamethasone. So in this instance, dexamethasone would help actually reduce some of the swelling and reduce the intracranial pressure that can make the patient feel a lot better. But this is something you'd speak to your senior, and depending on if you're an intern or a HMO, there may already be a hospital protocol, and that's what you'd be looking at in terms of how you'd be giving this medication. Good work, Louise. All right, next case. So let's go with Thomas.
Yep. So we've got an older man with quite comorbid. So he's got Parkinson's, so probably want to avoid any dopamine antagonists, so not metoclopramide.
Yep.
I'm probably not prepared or anything like that as well. So I guess I was thinking about ondansetron, but maybe just have a look if he's constipated already, and if not, give ondansetron.
Yeah.
Maybe, if not, maybe cyclizine.
So in this patient, cyclizine causes some sedation, and that might be something you're a bit worried about in someone that's a bit older as well. And I think antihistamines can often be a risk factor for delirium. So you might want to avoid it to some extent. So in this patient, you were right the first time. I'd give ondansetron in this instance. But before that, how would you assess this patient?
I guess I'd go to the bedside, kind of look at his stat, like if he's delirious or frail, or ask if he's constipated.
Yeah. So you talk about a history, an examination, and investigations. So with this patient, in terms of your history, you want to find out why they're nauseous, why they feel like vomiting. Did they open their bowels recently? Are they able to eat and drink? What's coming up when they vomit? Is it a hematemesis, or have they got any other things that make you suspect that they've got an upper GI bleed or anything like that? Are they sick? Are they febrile? You just want to understand why they're nauseous or why they're vomiting. It might be a medication that they're being given as well. Examination in an instance like this would be very much an endobetogram, having a look at the vital signs to make sure they're hemodynamically well, make sure they're safe, and then conducting an abdominal examination just to make sure that they don't have any abdominal pain and there's not a more sinister cause of this patient's nausea and vomiting. And then your investigations are very much determined by what you find. But typically, if you're worried about an obstruction, you get an abdominal x-ray, and your bloods very much are determined by the nature of the symptoms. You might opt to give a trial of an antiemetic, and if you give 4 milligrams of ondansetron and these symptoms completely resolve, potentially this is something benign, but have a high index of suspicion of thinking if there's any red flags. Just make sure you're able to rule those out. So good work.
Can I ask a question? What determines if we give 4 milligrams or 8 milligrams of ondansetron to different people?
So typically I always say start with the lowest dose, because then if they're still experiencing the symptoms, you've got more to give, as opposed to giving 8 milligrams and then it's overload and then they start to experience some of the side effects.
Okay.
So that's what I typically do. So the more you give, the more likely they'll get side effects. but the amount that they need to relieve their symptoms may actually be quite low. So you start with 4. If that's not enough, you give 8. So typically you chart 4 to 8 milligrams TDS, IV or PO when you're on the wards, and then the nurses can titrate it as appropriate. And they're usually very good at being able to do that. Does that answer the question?
Yeah, thanks.
Brilliant. All right. Oh, and in terms of the drugs you want to avoid metoclopramide, droperidol, prozine. All right, now on to the last case. And let's go with somebody I haven't asked before. I actually think I've asked most people in this chat. All right, that's all right. We'll take any volunteers who are open to this case. We'll go through it together, so it will be nice and easy.
Yeah, I'll do it.
Nathan, you are killing it. All right, let's do it. So you're the intern, you're in ED, you see a 27-year-old woman, they've got dizziness, nausea, and vomiting, right?
Yeah.
So what are you worried about at that point?
So I guess with the added dizziness, you're thinking of potentially a vestibular cause of her nausea and vomiting.
Nice.
And yeah, she's got a pretty bland history. You would still want to do a history and exam of her to try and figure out the cause.
I'll stop you there.
Yeah.
What's the things you don't want to miss in this patient who's got dizziness, nausea, and vomiting? I know they're quite young, but something you just definitely don't want to miss.
You don't want to miss like a central cause such as a stroke kind of thing.
Brilliant. Yeah. So talk me through your history, your exam, and your investigations very briefly.
Yeah. So history is going to be based, so any red flags, things like stroke. You want to ask about visual changes, ask about vertigo questions, ask about ear symptoms such as hearing loss or tinnitus. And then, if there's been any kind of reduced consciousness, any head trauma, if she feels unsteady on her feet, anything like this happened before. And then, your examination is going to be targeted at that. So you want to do a cranial nerve exam, potentially other neurological exams, and then you could do like a HINTS examination, and probably go from there.
Yeah, that's a next level answer, Nathan. You've done very well. So essentially, you're going to do the HINTS exam, see if it's peripheral or central. You're going to do a neurological exam to see if there's anything else there. And then you can do something called an Epley's maneuver. Dix-Hallpike maneuver, just to help diagnose to see whether this is, if it turns out to be a peripheral cause like BPPV, to be able to localize to which side it is and sort of confirm your diagnosis. And then if you're unsure, you have a low index of suspicion, to go ahead with a CT brain to check for a stroke. You might also think about doing some bloods in this instance as well. And what's your treatment for this patient?
So if you're thinking of a vestibular cause, you'd want to use something like potentially Stemetil.
Yeah, that's prochlorperazine.
Yeah.
So that has those dopamine-like effects, but it also works on the histaminergic and muscarinic receptors. And that's going to act on the vestibular system, like you just mentioned, to make sure you're able to improve those symptoms. Now, this is symptomatic relief. The actual treatment for someone with BPPV is to do the Epley's maneuver, and usually you discuss this with physiotherapy, and they're able to help the patient do that. And if they're safe, they can be home with some follow-up to make sure they're able to do those maneuvers and they're starting to feel better. So that's the way I would go about it. Now, any questions from this point onwards?
I guess I had a question around like the serotonin antagonists, but I know you said it's rare for long QT syndrome. What kind of patients, I guess, would you think it's contraindicated if they had if they had a history of heart block, or if they had other QT prolonging drugs?
If they've actually got that, there's a diagnosis, long QT syndrome. If they've got that might be a contraindication. You want to avoid giving drugs that are going to make that worse. Look, typically you could look at an ECG to make sure they don't already have a prolonged QT. And then think about whether there are any other drugs that could cause a prolonged QT as well. It's not something you think about too much because of how rare it is, but it is something to keep in mind and have that in the back of your head. So think about what medications are they already on and whether they will prolong the QT, whether they have diagnosis of heart block or prolonged QT syndrome. And then that would make you think, all right, maybe I shouldn't be giving this drug. And then you'd opt for something that may not have that side effect. But otherwise, yeah, you're completely right on all of those points. So I guess the important point to take from the chat that we've had today is think about the clinical context. What's the pathology? Make sure you rule out the red flags. Consider the patient's comorbidities, particularly Parkinson's disease, because you don't want to make it worse. And always be guided by someone more senior if you're unsure, particularly as an intern or a junior HMO. And as we discussed, some antiemetics can have serious side effects. So keep all of that in mind. Now, we've got some feedback up now. I know that if I don't get it done early, I don't do it at all. So please send your feedback. Be completely honest. I'm interested in knowing what I can do to improve for next time to make sure that these sessions are more targeted to your needs, so that you can get the most out of them. So feel free, put in your feedback. I'll give you guys a moment now, and then we can ask them any additional questions you might have about antiemetics.
I just had a question. Just again about ondansetron. Is it better to use sublingual or IV, or
that's a very good
efficacy
question.
and what should you use?
So if the patient's unable to tolerate oral intake, so if they've got a bowel obstruction, you wouldn't want to be giving them any oral intake because essentially it's not going anywhere, right? They're obstructed. And if they're nauseous and throwing up, whatever goes in will come back out. So in an instance like that, you'd go for IV. So whenever you're trying to with antiemetics, when you're thinking about what you're going to use, think, can they tolerate any oral antiemetics? If they can, you can give oral. If they're unable to tolerate that, I mean, we see patients with nausea and vomiting. They're essentially like vomiting 15 to 20 times a day. And in situations like that, IV is all you can really give, because whatever you give the patient orally will come back out. So that's how you make that differentiation. In terms of the exact efficacy, I think it's quite similar, but they definitely have different absorption characteristics. So it probably takes a little bit more time for the oral drug to work. But typically the thing that's going to make you decide between one or the other is whether the patient can tolerate oral. Any other questions you guys want to ask? All right, so we've got another one with sublingual ondansetron. Does it get absorbed through the mucous membranes of the mouth instead of the gut? I would say it'd be a combination of the two. So you'll get something coming in sublingually, right, as the wafer sticks onto your tongue. But in addition to that, you've got saliva in your mouth and you are swallowing some of it down as well. So I think it's a combination. All right, unless there's any other questions that you guys have, I think we'll wrap it up. Thank you everyone for attending. Again, give us your feedback. Let me know how it went. And I look forward to seeing you guys all again for another tune.
Now, what's new with ABCs of Anesthesia is that we're forming a whole bunch of very comprehensive courses for every stage of your anesthetic journey, from medical student to procedural skills, from foundations in anesthesia, as well as really important exam lectures and clinical anesthesia courses as well.